Good morning, good afternoon, or good evening, everyone. As usual, it is impossible to know what time it is for you because this is a global meeting, and so you may be connected from one part of the world or the next. It is an absolute pleasure for me to moderate the next in a series of keynote talks as part of the Hamlyn Symposium 2021, which I remind everybody started in the end of May and will continue with a series of programs up until the end of July 2021. And you can find all of these details on the Hamlyn Symposium website, which is hamlynsymposium.org. Today, I'm absolutely delighted to introduce our keynote speaker, Professor Alex Golby. As I know her personally and we have worked together, Alex is a most accomplished neurosurgeon and is the director of the Golby Lab and professor of neurosurgery and radiology at Harvard Medical School. She's also a member of the Clinical Expert Advisory Board for a project called Eden 2020, which we coordinate here from Imperial, and her feedback and support over the past 5 years has been absolutely immeasurable. Alex has spent the last 20 years reinventing the use of Fmri and DTI, which many of you will know are imaging techniques conventionally used in neuroscience to study brain function. But in her case, it is to make clinical decision on a single patient basis, which then influence planning and treatment to improve outcomes and even avoid keeping patients awake during surgery, which is often necessary in these cases. Professor Golby has also been focusing on the challenging area of intraoperative imaging, notably with her role of coordinator of Amigo, an innovative operating and imaging research suite which encourages collaborations among multidisciplinary teams of surgeons, interventional radiologists, imaging physicists, computer scientists, biomedical engineers, nurses, and technologists. And of course, needless to say, Alex is also an accomplished scientist and author with over 10,000 citations, of which half of them are in the past 5 years. And it is a privilege for me to introduce her talk entitled Creating Roadmaps for Minimally Invasive Interventions in the Brain. And I now hand her the spotlight. Alex, over to you. Thank you very much.
Thank you so much, Fernando, and all the organizers for inviting me and for putting together this innovative mechanism for dissemination of ideas. We've all been doing our best during the pandemic to continue with our work and our collaborations. And I actually think that there has emerged from this, at least in my world, an understanding that we are all actually much closer to each other than we appreciated. And we hopefully will be able to continue this type of distance gathering across distance. So let me start my slides. And do you see that?
Perfect.
Okay. So welcome, everybody. Thank you, Fernando, for your kind introduction. And I'm going to speak today about how we can use the various types of imaging and sensing to create roadmaps for minimally invasive brain interventions. And I know a lot of you are especially interested in robotics. And so I hope to give you the perspective of a clinician and also, as Fernando said, someone who spent a lot of time thinking about preoperative imaging for surgical planning and intraoperative imaging for guidance on how these methods might help guide our more minimally invasive brain interventions. So, image-guided surgery over the last 20 to 30 years has really revolutionized everything that we do in neurosurgery because it provides us with an understanding both before and during surgery of where critical structures are and where the targeted structures are. And what we try to do is to demonstrate the lesion, including its margins, and also demonstrate on an individual subject basis the critical functional anatomy. So, as you know, people's functional organization of their brain can vary, and it is especially likely to vary when there's a structural lesion, either of long or short duration, either by plasticity or by mass effect. So the goal really is to put this all together in a way that defines the relationship of the target area to those structures that we have to preserve in order to preserve patient quality of life. And then use this both for planning and then for actually carrying out the surgery. So I'm going to start with an example of maximally invasive surgery, to contrast with how we might start to think about minimally invasive surgery. So this is a patient of mine from a few years ago, a young woman with medically refractory epilepsy since the age of 2. And she had significant seizures with an aura, and then followed by tonic-clonic contraction and unresponsiveness. She was on 4 seizure medicines and having nearly daily seizures and was very impaired. And she had actually been considered for surgery over the 20 plus years since she had been diagnosed. But at the initial considerations, this was felt to be a too high risk proposition due to the location near the critical motor cortex. But we revisited this with the advances of the type that we're going to discuss today. And we were able to define our initial target on the basis of EEG, and then refine this by creating a functional MRI map of the critical motor structures, and use that to create the surgical plan for phase 1 of the surgery. And this is part of why I call it maximally invasive. So what we did is we implanted a grid, and you see here an 8x8 contact grid that's applied over the surface of the brain, as well as 3 depth electrodes that we placed. And then the patient is admitted to the hospital and maintained with this intracranial implant with the wires coming out of the head in the ICU. It can be very challenging for patients. But we use this time to accomplish a couple of goals. One is seizure mapping. And here you see the map that we've created of this 8x8 contact grid, as well as the 3 depth electrodes, looking for the areas of seizure onset, early spread, and then late spread. And at the same time, we also create this functional map of critical areas serving motor and sensory functions. And we integrate these maps together in order to create the optimal surgical plan. We then bring the patient to the operating room where we can perform this direct mapping. You see here, exposure of the brain, electrode for monitoring and marking points where we do or do not have a response. And then during the resection, we use subcortical stimulation, which is cartooned here in the bottom panel, to avoid injuring the nearby tracts. And we're able to do this now with great precision. And this is a post-operative MRI of our final resection. The patient was found to have a focal cortical dysplasia type 2B, which is one of the typical types that causes medically refractory epilepsy. And she became seizure-free and was able to taper off of some of her medicines to pursue school and to pursue what was her real passion, which was horseback riding. So this is an example of what we can do. And this is obviously a great success, but it is very invasive. And that has some real implications in terms of the challenge for the patient. So many patients, the idea of having electrodes implanted into their brain for a week or 2 in the hospital, and the risks associated with that is such a deterrent that they don't pursue treatment. So while it's very successful, I think we are all interested in how we may modify this type of approach to make it more minimally invasive. So how can we adopt and advance this type of mapping, both of the target tissue and of the structures to be avoided, so that it will be most amenable to some minimally invasive therapies? So what are we talking about when we talk about minimally invasive therapies? There are a number of these. Probably the two most adopted presently are laser interstitial thermal therapy and deep brain stimulation. There are other methods of closed loop stimulation, which are gaining traction. Focused ultrasound is a minimally or perhaps even non-invasive, depending on how you think about it, neuromodulatory method and also method of drug delivery via blood-brain barrier opening. There are a number now of efforts to develop therapeutics which may be delivered to the brain through direct installation, such as cells, viruses, nanoparticles, etc. And then a non-invasive neuromodulation using techniques such as TMS or low intensity focused ultrasound. These also require a roadmap in order to be effective and to avoid off-target effects. So really getting these methods to be as useful as possible depends on the ability to identify the target tissue, the structures that need to be preserved. And then it also requires the ability to plan the target and the trajectory to the target in such a way as to accomplish those goals of target tissue and structures to be preserved. And then also to monitor and modify the trajectory and the intervention based on events that happen during the intervention itself. So I'll talk a little bit about those. So let me start with what's actually very near and dear to my heart, which is cortical mapping. This is mapping of the gray matter function. As I said, it's very important to understand each individual subject's anatomy, which varies significantly due to many factors. Functional MRI really has been the workhorse of this because it's non-invasive. It has sufficient signal to noise to give us good data on individual subjects. It allows probing of multiple cognitive and other domains. And it's also quite readily available because it leverages technology that most hospitals have, which is MRI. There are other techniques of varying invasiveness listed here. And I think one of the great points that I think is important is that if we develop minimally invasive therapies, then we also have to develop minimally invasive roadmaps. Otherwise, that minimally invasive nature of the therapies isn't as useful. So I'll focus on fMRI, which, as you probably know, is a vascular signal. And we look for what's called the BOLD response, or the blood oxygen level dependent response. There are some novel approaches which are being worked on, which I won't talk about. This is just an example of very bread and butter pre-surgical mapping and what it allows us to do in terms of looking at the areas of this patient's brain for this lesion, which is right in the motor cortex by anatomy, and to look at the relationship to the hand area, the foot area, the supplementary motor area, to do this in 3 dimensions and to make a surgical plan. This is an example of a bit more advanced imaging. This is 7T imaging of language function. So this is about a decade on from the image I just showed you, and the ability to really refine the localization to the cortical gray matter in a way that wasn't as apparent with earlier studies. Then we marry this often with diffusion MR for white matter mapping. And one of the points that is, I think, very important to take home is that preservation of function in a patient depends on preserving not only the cortex, which we have perhaps more familiarity with mapping historically, but also, and perhaps even more so, preservation of the white matter tracts which connect those cortical regions. So you can see that in this picture, the volume of the white matter is quite a bit greater than the volume of the cortical gray matter. And we actually know that patients have more trouble recovering from a white matter injury than they do from a cortical injury. And that's probably because of the differences in the plasticity and compensation of nearby areas. Also, many tracks take a cortical region and funnel down as part of their trajectory. And so it's possible with a relatively small lesion to take out quite a lot of function. So we measure the location and trajectory of the white matter tracks using diffusion MR. These are variations on diffusion tensor imaging, which itself measures the diffusion of water in a directional way so that the water diffuses more rapidly and easily parallel to white matter, and especially to tightly packed myelinated axons, and to lower diffusion across the fiber. This can be converted into a tensor, which in turn can be converted into a map like this. This is a map from the early 2000s with very simple representations of the tracks. This is one of the first patients in whom we used this approach. And you can see the lesion there, and you can make out the relationship to the nearby tracks. And even the fact that there's kind of a cleft in that lesion with the tract running through that cleft. And we look at these lesions for the purposes of estimating tract displacement, infiltration, destruction, and edema, because those have different implications in terms of what can and cannot be resected. So the idea is that we can actually create very detailed white matter maps and use these to guide approaches to a number of different lesions. So neoplastic lesions in the supratentorial space, vascular lesions, guiding functional neurosurgery, which we'll talk about a little bit, and then also brainstem lesions and potentially looking at the cranial nerves as well. And we have a project in that domain. So the idea is that we want to be able to put this together and to, in an individual subject, find the tracks of interest. And this is an example using interactive software, which allows us to move a fiducial point, or this little sphere is a seed point, around the lesion to define those structures that we're, as clinicians, most interested in looking at. Like any computationally intensive method, there are a lot of different approaches to this. And I put this in kind of as just a caveat that using different algorithms can lead to different trajectories and streamlines. And so a real understanding of the mechanisms of how the streamlines are developed, optimization of tracking technologies is an important goal in terms of making sure that we have the best possible tractography. And this is an example from our group using 2-tensor tracking to track through areas of both edema and crossing fibers. So this is a patient with a lesion, and we're looking for the arcuate fasciculus, which is one of the key language tracks. And when we add a 2-tensor model, you can see we get much better tracking, especially in the region around the tumor, where we know there are crossing fibers and we know there's significant edema as well. This is an example of how we can look for critical tracks. And one of the challenges clinically is that, as you saw in that first picture of the brain specimen, the white matter is everywhere, but we have to try to define which are the critical white matter tracks. And we have a variety of ways that this can be done. Traditionally, it's been done by expertise and manually, for example, as you saw with that small fiducial, moving the fiducial around to look for recognizable tracks. But we also are very interested in creating an automated method of identifying critical tracks. And this is work with my colleague, Lauren O'Donnell, over many years, which has really culminated in a statistical white matter atlas, which was created by using data from the Human Connectome Project and creating a registration amongst those different subjects, and then an anatomical atlas hierarchy creation, which was done by our colleague Nikos Makros, a neuroanatomist. And by describing the shape of these critical tracks in terms of large-scale features and relationships to other structures, Lauren and her team have been able to create an atlas that's robust to things like mass effect. And so these are corticospinal tracts subserving motor function and the arcuate fasciculus serving language function in patients with significant lesions. And you can appreciate, for example, here, the displacement caused by a tumor. And these are examples in the patients demonstrating the tracking and also the presence of these very large and significant lesions. And then finally, I wanted to just introduce the idea that one method can be used to validate the other. So one of the critiques of these non-invasive brain methods is that they are not validated, and that the true answer is only obtainable through intraoperative electrocortical testing. I would argue that even intraoperative cortical testing has its challenges, very significant challenges, and we don't have any way of really assessing the validity or reproducibility of those methods. For example, some practitioners would argue you need to stay 1 to 2 centimeters away from any positive electrocortical site, whereas others would say you can come right up to it. So there's a real difference of opinion there. I don't want to belabor this point, but the idea here is simply that we can use the functional MRI cortical mapping to help validate and also understand some of the mapping from the diffusion imaging or tractography by looking for correspondences between these two completely different methods, one based on blood flow, one based on the diffusion of water, and looking for convergent evidence that shows us which areas are critical. In practice, we put this together for our open surgeries, and we use this for our preoperative planning, and we use it during surgery via neuronavigation. So this is just a screenshot from the OR, how we might use this. And this is also how the data can be integrated with the operating microscope. So the operating microscope is really the workhorse of open neurosurgery. The scope can also be tracked and put into the navigation system, and then these regions can be superimposed. And I show this picture because of a few things. One is it demonstrates to non-surgeons just how bland the appearance of the tissue itself is. So there's no indication of what might be tumor and what might be critical brain, because gliomas so often look identical to brain, and critical brain areas don't differ in their appearance from non-critical brain areas. So moving some of these ideas into minimally invasive approaches. And this really stems from an idea that my mentor, Frank Yoles, shared with me many, many years ago, which is that if you can see what you're targeting, then you can potentially really innovate in terms of how you target it. So surgeons, really as far back as you can think, see with their eyes and to some extent feel textures with their hands and proprioception, and make decisions on the basis of those two pieces of information. But really now we have all these other dimensions that we've been speaking of, and some may be able to supplement the visual perception of the surgeon, and some may actually be able to completely replace it, and even be better, so that you could know and understand more without opening the cranium than you could with opening the cranium. And obviously this is not just true of neurosurgery, it's true of many applications, but as a neurosurgeon, this is really, I think, it's what I know, and it's also an application where great precision makes a big difference. So when we think about these minimally invasive targets, we really want to understand what we are trying to target, either for ablation or for modulation. And the two that I work with the most are tumors and seizure foci. But there are no doubt many other foci. So foci for a tremor generator and DBS, functional neurosurgery, and especially functional neurosurgery directed at other neuromodulation. So this is not my area, but a number of targets are being developed for treatment of psychiatric illnesses and other illnesses. This is work from my colleague C.F. Weston and colleagues to better define tumor tissue. So again, without the ability of removing the tissue and presenting it to the pathologist, and even when the pathologist does get the tissue, it may take weeks presently to get a full characterization of the tumor due to the reliance on genetic markers. And also, there's great heterogeneity within tumors. So being able to get a handle through advanced imaging on exactly where the tumor is, where the margins are, is really critical to developing approaches. And I'm going to speak about this especially as it pertains to drug delivery. And I'm going to just point out these novel measures of diffusion in the two bottom right panels, which demonstrate different areas of the extension of the tumor. And our goal really is to try to differentiate infiltration from edema so that we can really target additional therapies. This is another use of the same diffusion imaging, which is called QTI imaging, to demonstrate different types of tumors based on the microstructural diffusion of water. Another important target definition technique which is emerging is MR spectroscopy. And for gliomas in particular, we have been making a lot of use of 2-HG spectroscopy. So 2-HG is 2-hydroxyglutarate. This is a metabolite which is seen in IDH mutant gliomas and only in IDH mutant gliomas. And my colleague Alex Lin and his colleagues, including partners at MGH Martinos, are able to, in addition to the more conventional spectrographic signature, create a 2-HG signature as well, and extract this and really quantify it. And this is really has proven invaluable on multiple occasions to help us differentiate tumor from non-tumor, and also to help us understand the biology. So tumors that are IDH mutant have a very different prognostic implication than tumors that are IDH wild type. There are other methods potentially for sensing tumor. This is work from my former colleague, Dan Oringer, using Raman spectroscopy to create a histologic-like picture without staining the tissue or freezing the tissue. And this type of real-time feedback can be very important. This is beautiful work by Frédéric Leblond and colleagues trying to harness this type of technology for actual in situ diagnostics. So putting this type of approach into something like a biopsy needle in order to guide the biopsy to improve yield and reduce complications. I think machine learning may end up playing a big role in this type of approach, because if we want to get the data quickly, and there's a huge amount of the data, what we have to think about is how can we create technology which takes data and makes it informative to the clinician, because the clinician doesn't want to pour through huge amounts of data and have no idea about the sort of conclusion and also how much confidence one might place in the conclusion. So I think that it's important that we think about how to present data so that it's most informative. This is related work done by my colleague, Natalie Agar, using mass spectrometry. And she is able to tell us about the subtype of tumor, the grade of tumor, and even the concentration of tumor cells, so that we could be aware of when we're reaching a tumor cell gradient drop-off. She also has the ability to image the metabolite 2-HG and use it as a quantitative marker of cell concentration. For seizures, there are a number of ways in which we can non-invasively define the seizure focus. This is example from another group using MEG to define the seizure focus in a patient who's already had a large temporal resection but continues to have seizures. Stereo EEG is a method which has harnessed robotics in order to place depth electrodes in a minimally invasive way. This is a cartoon, but these electrodes are placed through tiny little twist drill holes. The patient does not have any type of craniotomy. The data from the electrodes can provide very detailed maps of seizure onset zones and allow really crafting of a target. And increasingly recently has been married with laser interstitial thermal therapy, which I'll discuss, to ablate the zones where the seizure onset appears to be. And that can potentially be very applicable to a patient like the one that I started with. The idea would be to really minimize the amount of disruption, although it still does require a period of implantation. The stereo EEG electrodes are much less invasive than these big grids that we put subdurally. Another thing we have to think about when we plan our trajectories is minimizing risk. And for us in the brain, the biggest risks that can cause unanticipated complications is bleeding. And so we try very carefully to avoid blood vessels. And this work I found in preparing for this talk just demonstrates for the layperson just how many blood vessels there are. Also, how different methods can reveal different levels of the blood vessels. So the brain is filled with blood vessels. For those of you who don't work in the brain, 25% of the cardiac output goes to the brain. So we're operating in a field of blood vessels, but what we would like to do is define any where injury could cause bleeding, or another feared complication is a venous infarction. And to do so, this raises the issue of potentially creating curved trajectories. And Fernando knows this work well. This is work in our group using software to try to plan trajectories which can take into account the location of sites that we wish to avoid, such as a cortical blood vessel, or in this case, the ependema of the ventricle, and still cover the regions of interest, which in this case is the hippocampus and the amygdala, for laser ablation for seizure surgery. Similarly, deep brain stimulation can benefit from the same types of approach to avoid structures such as superficial blood vessels, the corticospinal tract, and deep blood vessels. This is work from my colleague Sonia Pujol and Reese Cosgrove, my clinical partner, who's a functional neurosurgeon, looking at very detailed tractography data around the subthalamic nucleus, which is the surgical target in Parkinson's disease, and looking at the relationship of the tracts which we wish to neuromodulate, those communicating with the globus pallidus interna and externa in peach and green, and avoiding or minimizing off-target effects in the corticospinal tract, seen in white, and even looking in this sort of semi-transparent view of the interactions and areas of crossing between those two separate fiber systems. And this is an example from an outside group, but looking at this to refine targeting. So this is a clinical case in which the patient had the electrode placement, which is shown on the left panel in blue, and did not have good responses. And they removed those electrodes, did this type of advanced imaging, and planned a new implantation taking into account the target and on-target goals. And this is a retrospective analysis, but shows the improvement in that. And this has been taken and expanded to other targets. This is not my area of clinical expertise, but for the targeting for psychosurgery and in this case for obsessive compulsive disorder. These are gorgeous images. You can see the 7T anatomy in the background and tracks defining the anterior limb of the internal capsule for the target, and then other structures to avoid off-target effects. We use this type of approach for LIT planning. So LIT is laser interstitial thermal therapy. This is a minimally invasive approach which is used for tumors and for epilepsy in the brain. And this is from one of my patients where we had to plan a rather long trajectory with all sorts of critical structures serving motor, sensory, visual, and language functions, and bringing that all together and creating the optimal trajectory. This emphasizes really the importance of planning. During LIT, we also do monitoring. And so we monitor the temperature. Some advanced LIT methods are able to do side firing laser so we can more shape the ablation zone. And that requires integrating sort of knowns and unknowns. And this is work from my colleague, Sarah Friskin. This is in a data set of amygdala and hippocampus as targets for laser ablation for epilepsy. And these are complex 3D structures. This is what's motivated some of our curved trajectory planning. But also there's error associated with both the outlining of the structure by different raters or different judges of the target structure. And then there's the additional error introduced by the trajectory and compensation for that error in real time. And we've been very interested in how to visualize uncertainty. So one of the challenges practically for clinicians using image-guided therapy is that sometimes there appears to be a discrepancy between the guidance and what other cues and clues are telling us. And when that happens, the clinician doesn't really have any data to decide what might be wrong and whether to wholesale throw out the map that they've created and usually spent so much time generating, or modify it. And so we're very interested in how we can demonstrate to the clinician the degree to which their location is certain versus uncertain. And finally, there's the guided delivery of therapeutics. This is work from my chairman, Nino Kioka, instilling viral vectors into patients with recurrent glioblastoma. And I'm enthusiastic that this approach is going to be very important because of the fundamental ability of the viruses to change tumor biology. But we also have to make sure that the targets are correct and also better understand any variations in the lesion and what areas may represent treatment effect versus recurrent tumor. Now I'll talk just a little bit about focused ultrasound, which is one of the newer therapies that we're using, but it goes back quite a long way. You can see from this comic book the idea of using focused ultrasound to treat inside the brain. A lot of this work was done by my colleague Nathan McDonald and my former colleague Claire Bohinanen, who's now in Toronto, of the ability to target through the closed cranium very precisely. And now we're using this method for blood-brain barrier opening. And this really circles back to this idea of where exactly is the tumor? Where are the margins? Where's the infiltration? How distinct is the margin in these tumors which are known to be infiltrative? This technology harnesses focused ultrasound with the administration of microbubbles. Intravenously, the microbubbles act as resonators and help to open the blood-brain barrier. Once the blood-brain barrier is open over a zone, then we can administer the chemotherapy. This is a picture from one of our recent patients. So this is very exciting to me because we really have moved into clinical trials at this point. On the left panel is our targeting of areas of blood-brain barrier opening. On the right, on the middle panel is a estimate of the dose that's been delivered. And then in the right panel is the post blood-brain barrier gadolinium enhancement in areas that did not previously enhance, indicating that the blood-brain barrier has been opened. There's still a lot of work to do in making this technology better and more applicable to our patients, but it's very exciting to me. So this is really what I wanted to share with you today. There's a lot going on. All sorts of investigators have many different technologies which they can bring to bear in developing these innovative treatments in the brain, in better defining target tissue, and as far as brain tumors go, especially tumor heterogeneity, which we know is a huge issue. As I led off with, the need to demonstrate individual patient anatomy, because there's great variability from patient to patient, and show those critical cortical areas, critical white matter tracts. We need to be able to develop trajectories which incorporate both the goals and the constraints, and that may involve the development of complex trajectories, including curved trajectories, and to modify those plans based on data that we may obtain intraoperatively through a variety of sensing mechanisms. So I think there's a lot of potential directions, a huge opportunity for technical experts to collaborate with clinicians like myself. And that's what I hope to kind of set the stage for more collaborations. I've, as Ferdinando mentioned, had the opportunity to be a small observer for the Eden 2020 project, which is very exciting. And also to just plant the idea that some of these technologies, I hope, will be able to free us from some of the very intense resource needs of these approaches. So not only are many of these predicated on MRI, including intraoperative MRI, but they also require, in many cases, tremendous human resources with postdoctoral fellows dedicated to making this happen. And if we want the broadest adoption, we really need to try to develop methods which can be deployed in more lower resource settings. So thank you very much for inviting me. I think I went over a little bit. I want to thank all of these people and more who contribute to this work, and especially to point out my gratitude to my mentor, Frank Yoles, who you see here, who passed away about 5 years ago, but who really planted in me all of the ideas that I talked about today. So thank you very much.
Wonderful. Thank you very much, Alex. That was one amazing talk. I have to say, I'm a technologist, and I'm a technologist in medicine. So actually, you know, brain science and neurosurgery continues to captivate me the most. I mean, you presented some incredible pictures, which would have basically looked like science fiction only 5-10 years ago. I suppose, and this is a question from Karthik, but I think many would echo it. We understand brain more than we ever have, but how much of the brain do we still not know anything about? And are there things that we could invent that could help you along that journey?
Well, that's of course a huge question that goes beyond even clinical neurosciences to basic neurosciences, about all of the brain areas that we don't understand well. So there are investigations that can be done, I think, in healthy subjects, and then there's also the investigations that can be done in subjects with various neurologic illness, and those really differ. So, and the question of how you measure that, do you measure it by looking at various signals, or do you measure it just by looking at how the patient behaves, how their day-to-day interactions are? What are the biomarkers that would indicate, for example, a successful treatment in OCD, or a successful neuromodulation in a patient with a seizure? There are definitely technologies coming along, but how to deploy them, I think, requires really careful thought.
And if I were to say, so obviously, because we're making incredible strides on this, on the imaging and the non-invasive side, and you've already presented what you can image by processing complex MRI. And then, of course, there's still, I guess, the gold standard, which is sort of intracortical measurements, right? So open surgery. Which one will come first in trying to fill some of those technological gaps that, because you want to harness information from the brain, and at the moment you're trying to, the standard is to take measurements on site, and that's an invasive process and it's a scary process. But then, of course, imaging is falling short of giving you everything you need, so that you still basically need both, or in fact one is preferable to the other. Which one do you think will get us? So which advancement will come earlier? Will we get there on the imaging side, making a lot of the open surgical procedures redundant? Or is it more likely that we're just going to get better at taking those measurements through the skull in a safer, less invasive, less traumatic, and more robust way?
So I think that the reliance on intraoperative electrocortical mapping as the sort of gold standard can really lead us astray. It's intuitively an attractive gold standard.
Sure.
Because you get data and the patient stops talking, and so you must be interfering with language function, for example. But what we also know is that many patients who emerge from surgery with a deficit recover from that deficit over the ensuing days to weeks. And what we don't have is a way of predicting really accurately who is going to end up with a deficit versus end up without a deficit. So what those processes might allow to recover through simple things like the regression of post-operative edema and swelling, and also through more complex processes like plasticity. And we as clinicians have been notoriously very bad at actually measuring some of the more meaningful neurocognitive outcomes. So I just heard a really brilliant talk by one of my colleagues from Trondheim, who points out what's very true is that if a patient comes to your office and she or he walks and talks, well, then they're neurologically intact, right? And we know that we're really underestimating the degree to which our interventions interfere with some of the more higher level functions. And we need to start looking at things like, how are people's relationships with their family members? How is their job performance? A huge number of our patients undergoing brain surgery, even for low-grade gliomas, are not working. And why are they not working? Are they not working because they have difficulty with the performance of those more sophisticated tasks? So I think this is an opportunity for us to bring neuropsychologists, psychologists and psychiatrists, occupational therapists, physical therapists into the dialogue, because the outcomes we're looking for are so complex and nuanced.
So the million-dollar question then is the data hidden? Is the pattern hidden in the data? Or do we also have to engineer better data acquisition methods? So, I mean, I understand there's a plethora of stuff that we completely disregard because it's just humanly impossible, to just, because our second, third, fourth, fifth order problems. At the moment is, you're alive, you're walking, you're good, but then you don't know that, that particular relationship changed. So is the pattern, are those nuances hidden in data that we already have, in which case machine learning could come to the rescue, or is it also a technological barrier? So there's something we should be measuring better.
I think it's both.
And on the technology side, if you were to say, if only as a surgeon I could measure that, is there anything that particularly comes to mind? Right, because obviously we can measure we can take cortical measurements of electrical signals. We can do amazing imaging in 3D with Fmri and BTI and so on. But is there something you cannot do, which if only you could do, man, life would be a lot easier for a neurosurgeon?
Well, I mean, I think my list looks like a 7-year-old's Christmas list, right? It's long. There's so many things, right? So I think one of the opportunities we have with imaging is to look at the whole brain, which even with the most invasive surgical approaches, we can't look at the whole brain. And so if there were ways of recording from individuals' brains in such a way that we could understand something more about their day-to-day existence, and as opposed to,
But, and Alex, what do you think ideally the granularity of that measure? So at the moment, the granularity of your electrical measurements is as gross as it comes, and that's already massively invasive, right? But we also know that if you think of axons and electrical signals within the brain, the granularity is microscopic. So is there a sense within the clinical community as to how many data points would we need to have at least some better understanding of the important pathways of electrical signals going through one part of the brain to the other? So how many more measurement points? Is it hundreds, thousands, it's hundreds of thousands, and so on?
I don't know the answer to that. But my sense is that more than just the numbers of measurements would be the types of measurements, because I don't think a single type of sensing will answer all the questions. For example, diffusion MR is very good at looking at the structure of white matter, but it doesn't tell us much about the function of that white matter. In order to understand that better, we have to put it together with some other method. And so my sense is that if we can do two things, one is create statistical understanding of the variation amongst humans that are not ill, so healthy humans, based on their cognitive strengths and weaknesses, based on their age and neurodevelopment, based on aging and the development of aging-related changes, then we'll be in a better position to place a single subject who's potentially going to undergo an intervention in this better understanding of the general landscape, and come up with understandings that would be akin to saying, Well, we know what the blood pressure of 40-year-old males range is. And for a given individual, we can say with quite a bit of confidence what their blood pressure measurement says about them relative to health. So we can do that now because we have the population data. We can't do it at all for brain data.
Right.
So
continues to be most fascinating organs in the body by a mile, and certainly, I think the focus of this century's greatest discoveries. I'm pretty sure. Going back to the core community of this symposium, which is obviously surgical robotics, Kevin Clearing asked, in all of this, from a clinical perspective, where do you think robotics could be the most effective? I mean, you know what we do in needle steering, and I think that is one area. Are there other areas where you think, oh, yeah, robotics either already does a great job, or if only robotics did this, we would have a much better set of outcomes or a more effective system and so on?
So I think that the curved trajectories, needle steering, really could be important because it's amazing how many constraints we have on our targeting. Now that we have better visualization, we can see that sometimes we are like really threading the needle. In terms of which applications, so what's challenging, and I think what you alluded to, Fernando, is that since we're still understanding so much about the physiology and pathophysiology of the brain, that's evolving in parallel with the technology to access the brain. And so we don't know yet really which targets might end up being the like killer app, because it might be for a treatment that we're not currently using very much. So for example, we know that mental health is a huge public health challenge. It dwarfs brain tumors. But we're just getting to the point where we are beginning to understand some of the brain basis of those. So we need much better measurements and much better delineation of the targets. And then we need biomarkers which can help us understand whether our interventions are effective or not.
So we just published a paper with the same group you mentioned in the talk, which is Vijay and John Duncan from UCL, where we basically did a retrospective study to say, okay, they did a lovely study on the efficacy of LIT and how you could, by optimizing your planned trajectories in LIT, you could actually get better coverage and a safer, more effective procedure. And then we took it one step further and said, okay, if you had curved LIT, if you could actually then release the constraint on a straight line trajectory, how would things look? And obviously the results on paper look really good. So you know, having an accurately placed curvilinear trajectory within this pathology or therapy would actually help. But devil's in the detail. And as you know, building a needle steering system in the lab is great, and it's controlled and it works. And then you look at the reality of neurosurgery and you're humbled by what you do on a day-to-day basis. It's really quite special. Yeah.
Well, and also the sort of regulatory requirements are so high for an implanted mobile device that travels through the tissue. It really is a very high bar.
Yeah. And of course, then you go into tumors and you think of aggressive malignant tumors of the brain, and the lay engineer thinks of a ball within a bigger ball, and in reality you look at a glioblastoma and it's incomprehensible. And so I think whatever will eventually help us to tackle that particular subject is not yet here. There is no one mechanism from an engineering or a clinical point of view that would actually really sort of allow us to do a good job there. Right. So there's a short question. I suppose we just have a 30-second answer, and that is from an anonymous attendee who says, CSF, deliquoration during brain surgery, so brain shift, how big of a problem is it?
So I actually had some slides about brain shift. So brain shift is a very big problem for open surgery. One of the benefits of minimally invasive surgery is that there's much less brain shift. But that's not to say there's zero. And so monitoring changes in the location of the target, as well as unanticipated deviations in the trajectory, how the actual trajectory deviates from the planned trajectory, is a really important technical challenge that has to be faced.
And then there is work from colleagues from Munich and others who are looking at ways to address this by looking at what's happening in surgery. But interventional MR, which is the gold standard, is so inaccessible and so inexpensive and so expensive, as Alex said, that it makes it very difficult to scale up. So unless you are an elite center of excellence with access to an interventional system, it's not the sort of thing that anybody can do.
And so even for us, where we do have access, it's a limited resource. I'm having negotiations all day today about who gets Amigo on a given day.
But because the ask is the bottleneck is access to the suite, basically.
Exactly. And then when you are in the suite, the bottleneck is time. Yeah. Because it's very, very time consuming.
So plenty of food for thought for the engineers and scientists in this in the audience. I mean, this is a fascinating topic. I could speak about with Alex for hours and hours, but our time is up. I'd like to thank Alex for a wonderful talk. Remind everybody that this presentation will eventually make it to our YouTube channel. And of course, there will be several other keynotes dispersed through the next month and a half. So please do use the website to find what, when, and how, and to register. So thank you very much for joining us, and I wish you all a happy rest of the day. Alex, thanks again, and see you soon.
Thank you so much.
Take care. Bye-bye, everyone.